Good evening, everyone, and thank you for joining us tonight for yet another Hazelhurst CPD series. And tonight we are going to discuss hand and wrist issues in general practice. My name is Lydia Koenig. I'm CPD Program Officer here at Central and Eastern Sydney PHN, and also working with us tonight is CPD and Events Manager Bertha Harvey and our GP Facilitator, Dr. Janine Hopkins. Before we begin, I'd like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise the continuing connection to land, water and community and pay respect to elders past, present and emerging. I'd also like to extend that respect to any Aboriginal or Torres Strait Islander colleagues joining us tonight. And I would like to pass it on to our GP Facilitator, Dr. Janine Hopkins, and Janine is one of the GP education advisors for the South region. Thank you, Janine.
All right, thanks, Lydia. Look, I'd like to welcome our two speakers tonight. Dr. Sarah Yong is an orthopaedic hand surgeon. She graduated from medicine at New South Wales University, and she also has a Masters of International Public Health from Sydney University. Dr. Yong trained in orthopaedics at multiple referral centres in New South Wales, including St George Hospital, Sutherland and Liverpool hospitals. She then undertook additional subspecialty training in hand surgery, both locally and overseas in the United Kingdom at Chelsea and Westminster Hospital. And besides elective hand surgery, she's also experienced in managing hand and wrist trauma. She's a member of the Australian Hand Surgery Society and the New South Wales Hand Surgery Association, and her practice rooms are at Kogarah, and she operates at St George Private and Kogarah Private Hospitals. Dr. Yong says her favourite activity, if she does get any spare time, is reading, but she's kept pretty busy with two children aged 4 and 6, and also she's married to an interventional radiologist who happens to be away this week at a conference. So with such a busy week, we're very, very grateful for her to take the time out to do this talk and teach us and to share her expertise tonight. So welcome, Dr. Yong. And
thank you.
Also tonight, we'd like to welcome George Kikilas. He's a physiotherapist and accredited hand therapist who works solely in hand and upper limb rehabilitation. George graduated from Western Sydney University in physiotherapy in 2013. He started working exclusively in hand therapy 2 years later at the well-established practice Southern Hand Therapy, which has clinics in Kogarah and at Sutherland. He's become the principal of the practice and leads a team of physiotherapists and occupational therapists who solely work in managing hand injuries. He lives with his young family in the St George area, and he's also kept busy with his 2 kids. So with all their experience, tonight George and Dr. Yong are going to give us a talk about examination of the hand as well as a variety of hand and wrist conditions. So a warm welcome to you both. Thank you.
Thank you.
Thanks for having us.
What I might do is I'm going to start sharing my screen so we can get on with it. Hopefully everyone should get this up. So I've given this talk in a different form before. And how we like to do it is I like to give people some general principles when you assess a hand, and then move on to look at common hand conditions and apply the same principles that we cover. So I have no declarations of conflict of interest to make. So here we go with the outline. I'm going to talk about a brief 15-minute clinical assessment because, let's face it, no one's got time. We're going to move from that to investigations and then look at treatment options. The clinical examples we're going to cover a fair amount, so we're going to move quite quickly. And if you've got any questions that you wish to raise or comments, there is some time at the end to take some questions and comments. But also there's a question and answer box that I'd be happy for you to list your questions in. So let's get started. How do we assess the hand in 15 minutes? It seems like there's so many things going on and there's all these fingers. But when we take a history, I tend to be quite quick about it. I talk about whether they are right-handed or left-handed and what do they do for work. And I ask them who they live with because it's relevant if they have surgery and someone needs to help them around. And finally, what they like to do in their pastime. And then we move on to look, typical medical history, the history of the presenting complaint. We look at how long these symptoms have happened. Is this acute, subacute, or chronic? Was there an injury? Has there been a change in symptoms? Has the lump gotten bigger? Has the pain gotten worse? Is the hand numb? How does this impact on the daily function, which just ties back into job and hobbies? And have you tried anything? What have you tried? Has it made it worse? And how many times have you tried doing that? So usually at this stage, they haven't tried hand therapy, and that's when we start. It's a great start for hand therapy. And then past medical history, when I get the past medical history from GPs, it's usually really thorough. It's really got their medications in it and a list of stuff that they've been, that patients have had. So I usually find relevant things for me as a surgeon would be if they're on antiplatelet agents or if they smoke. Now, orthopedic surgeons are pretty simple. We like to look, feel, move, and do special tests. So here we go, look, feel, move, special tests. So when I look at stuff, I like to look at the skin. I look for swellings. I look for the color, or for evidence of good circulation. I look for deformities that give you a little hint as to what the patient's like. Probably more pertinent to the neurological exam, you look for wasting in the muscles of the hand. And when you feel the hand, we feel for temperature, tenderness. Trophic changes are things like when they lose their hair, or if they have altered sweating or temperature. These things are the kinds of things you see in complex regional pain syndrome. And with regards to sensation in the hand, normal sensation is fine, but sometimes abnormal sensation presents in 3 different ways. Hypersensitive, so hyperesthetic. Dysesthetic, where it feels different from what you expect, which means, for example, things like pins and needles, or if you touch them, they say, I know you're touching me, but it feels like cotton wool. That's altered sensation. Anesthetic is complete numbness, so they can't feel anything at all. And then we get the patient to move their hand, and usually a good composite test is to get them to make a fist and to open up. With the thumb, is to get to see how far along their fingers they can go before they kind of pose. So it's a really quick test to see how they go. So that's active. And if they can't do that, then you head towards moving the patient themselves. Special tests tend to pertain to the structure that you're examining. So nerve tests, for example, provocative tests such as Tinel's test and Phelan's test over the carpal tunnel sort of bring out the irritability of a nerve. Froment's test is more of an indirect test of the functionality of the ulnar nerve and the way the patient compensates for when an ulnar nerve isn't working so well. And then mechanical tests, orthopods love mechanical tests. The grind test for arthritis, we do that in the knee. We also do it in the thumb. Finkelstein's test is another provocative test that we use to stretch a tendon out to see if it's painful into Quervains. And obviously stability tests that we use for ligaments. And we'll show that in some of the videos we have. Throughout the talk, you'll find I have little areas where hot tips come up to help sort of like target some of the stuff you want to do when you see a patient. I think, and I find that these can be quite useful. Investigations, we generally start with an X-ray, sometimes an ultrasound. MRIs, I can order. I'm more than happy to do that. I think that's more rebatable for a patient. CT scans, if you're concerned about bony problems or joint problems. Nerve conduction studies, bone scans, and blood tests are the kinds of things we look at. Blood tests, in particular for hand surgery, is we look at rheumatological screens. And then we talk about how to manage this patient. How do we start the initial treatment, and then how do we move to referral? So a little mnemonic that we learned when I was doing my fellowship exam was Elm Poppy, where we talk at things like, when you deal with the patient, you educate them about the kind of stuff they should avoid doing. Those kind of stuff that you encourage them to do. Lifestyle modifications that they can make. Pharmacology would be things like NSAIDs, paracetamol. Orthotics would be the sort of stuff that George makes, splints, braces. Physiotherapy, again, that's George. It's also occupational therapy. And injectables like cortisone. And then finally, we talk about referrals. Then you can go through 2 paths. We can go through hand therapy or direct to a hand surgeon. So Sydney Hospital basically drains the Shire, and then all the way down to Wollongong and slightly beyond that as well. So everywhere south of the Sydney Harbour Bridge is what Sydney Hospital drains. So they're extremely busy. Here's the ways you can refer to Sydney Hospital. You can speak to the hand registrar on call, and there's the phone number right there, and they're going to hate that I've given it out. Consider hand therapy referrals for closed injuries. So I know that St. George Hospital has a hand therapy department that they don't tell a lot of people about, but it is there. That's the email. They prefer referrals to be emailed to them, and they contact the patient for you. That's their direct phone number as well. And of course, the private hand therapists like Southern Hand Therapy, George's practice actually has fracture clinics that they run every day, and they give you same day assessment. So really, really useful. They're open till 6 o'clock. So after work on Mondays to Thursdays, until 5 on Fridays. So closed, just to give you some context about what it's like when you refer someone to the public hospital or the public hospital clinic. Closed injuries often wait for definitive treatment, even if they get seen sooner, for up to 2 weeks. Sometimes I think they're running to 3 right now. So that's really quite pushing it. And often they get cancelled or deferred repeatedly, at least like twice. So patients just have to understand that that's the premium you pay if you go through the public system. It's not money, it's time. Hand clinics are run daily. They see a minimum of 70 patients per morning. Usually it's more. And sometimes if a private patient or work cover patient is seen in those clinics, they get moved into a consultant private operating list somewhere else, so to offload the system. So that's how it kind of works. Let's go through some common conditions. And I'm going to show you how you can actually assess, manage these conditions in 15 minutes. Carpal tunnel syndrome is so common. It turns out to GP practices a lot. So the carpal tunnel, as you can see from this diagram, very useful, download it from the web, that's my source, is that the nerve sits under the transverse carpal ligament. So what I tell people is that it shares the compartment with nine tendons, and things like flexing your wrist and gripping causes the tendons to bulge. So you go from normal pressures within the carpal tunnel of about 2.5 millimeters of mercury to about 30 millimeters of mercury. But in carpal tunnel syndrome, they can actually have a resting carpal tunnel pressure of 30 millimeters of mercury. So it's already high. And then when you get them to do that, they go up to 90 millimeters of mercury. So it's significantly greater. And what happens is the nerve goes to sleep inside the hand. So you get those things I was talking about earlier. You get hyperesthesia, so hypersensitivity of the nerve. That's Tinel's test. You get dysesthesia, pins and needles. And sometimes you get numbness, anesthesia. So those kinds of things present with these nerve injuries. Loss of causes, idiopathic is the most common. So classically, they turn up and they say, I wake up in the middle of the night with like a dead hand. Usually it's these 3.5 of this. And I need to shake my hand out, hang it, change position, put it in hot water to get the circulation back, they say. And it's the classic distribution. And this, if they turn up like this, that clinical diagnosis is made for you. Most of the time, patients aren't that helpful. They say the whole hand goes numb, and that becomes a little bit more confusing. On examination, I had to take you through this with a video that George and I made. We look for the wasting of the thenar eminence. We feel for where they're numb or where they have altered feeling. We test the abductor pollicis brevis, which is the main muscle that is supplied by the median nerve and the median nerve only with no cross cover. And then we do special tests for the nerve. So I'm going to go through this. Here's your hot tip. If your patient has thenar muscle wasting, put that on your referral because it helps to prioritize the patient. For reference, Sydney Hospital has up to a 1-year wait list to review a patient with carpal tunnel. If the patient has thenar muscle wasting on the referral, it goes from 1 year waiting to 3 months. So if it is quite a useful thing to know, because if you don't know to put that on there, your poor patient will probably wind up getting ongoing wasting. And by the time they see the guys at Sydney Hospital, it's a bit late. So put that on the referral. It's a great hot tip. Here we go. That's George's hands. I'm going to go through the examination as I play the video. So we look for wasting the thenar eminence. That's the thenar eminence, is the pad of the thumb. And then we feel for sensation at the base of the pad. That's the palmar cutaneous branch of the median nerve. And then you compare the little finger, ulnar nerve, and the index finger. And then you compare both hands to make sure that they're the same or not the same in carpal tunnel syndrome. To test APB, you get the patient to abduct their thumb like so and push against them and test their strength. And you can see the muscle bulge right there. Special test, Tinel's test, extend the wrist and tap along the carpal tunnel. Usually people with carpal tunnel syndrome get a reproduction of their symptoms with that. Phelan's test usually involves holding the hand in this position, increase the carpal tunnel pressure, I like to do a direct nerve compression test. So I combine Phelan's and I put my finger on there. And the reason for that is because Phelan's test, a positive test, requires about 2 to 5 minutes of pressure, whereas the direct nerve compression test actually brings about the positive results a lot sooner. You don't have time for 2 minutes of sitting there holding the patient's hand. That's the video. And that is a really quick examination of the carpal tunnel done in under a minute. Some of the questions I get asked really commonly are nerve conduction studies necessary? Carpal tunnel syndrome is really a clinical diagnosis. And so when you see someone with those really classic presentations that I talked about, it's not really necessary. And if the patient has constant numbness, that qualifies as severe, and that goes on to surgery pretty quickly. Nerve conduction studies are when it's a little bit more questionable. They say, oh yeah, but it's all over the hand, or it's an unusual distribution, or they don't have all the positive signs or history even. So nerve conduction studies become kind of quite useful. For patients who are sort of work cover as well, work cover does prefer nerve conduction studies, and the reason for that is they want to quantify that the patient's had actually got this. They don't tend to accept just a clinical diagnosis, but that's work cover. Also, I think that it does provide a good pre and post-op measurement. So you can see what they're like before surgery. And if you have that and you think that your patient's not improving despite a release, having nerve conduction studies helps.
Can I ask, Sarah, do you find them beneficial for them to have that before coming and seeing you? And how imperative would you say that is?
Look, I would say that it comes down to urgency. You know, if this is a very, very acute carpal tunnel syndrome with the classic symptoms, don't bother because it's acute. You know, it's easily reversible. We can easily manage this like straight away, and then it goes away. It takes about a month to get nerve conduction studies for the private. It's certainly longer if you go to the neurophysiology department at St. George Hospital. So you don't want to delay treatment. Not entirely necessary.
Yeah, I agree. And it's probably the same with the ultrasound as well. It's just I find they're useful to have, but in terms of waiting, that I would say for I guess how critical is for my let's say diagnosis. I've seen the severe ones bounce back quite nicely with conservative treatments, and the acute ones and the ones that say mild are the ones who need to go on for surgery. So they are really nice to have, but I think probably the urgency is more the referral to either therapy or to the surgeon, rather than I guess waiting for these scans to sometimes be had. They are really nice to have. They are pricey at the same time. So I like them, but don't, let's say, love or need them at the same time. But very useful with mixed nerves, bilateral hands, and that can really help quite nicely.
Also quite useful if the patient tells you they also have a history of neck pain, and you start thinking to yourself, is this a radiculopathy from a nerve root in the neck? And I picked up a few of those, which is very useful. Hand therapy is key, so I hand over to George.
Thank you. So for me, I'd probably say that my biggest differential to I guess either holding onto that patient or quickly referring them on is always wasting of that thin eminence. I find if I'm seeing that, so it looks like the muscles, and it's always nice if we've, hopefully got two hands there to compare sides in your almost objective assessment. But when I do see wasting, they are ones that don't. I might be able to improve their pins and needles numbness and tingling, but they do need almost always to go and see the surgeon, because otherwise that is irreversible. Whereas if we can get them into the mild and moderate stages, when their symptoms are mainly sensory, pins and needles, numbness and tingling, then therapy, I tend to find anecdotally, would be 7 to 8 out of 10 do settle down with just this. So default answer is a wrist brace. So this is one that's we call a prefabricated one they can pick up from most physio clinics, one that Amazon and Chemist Warehouse will have. There are custom thermoplastic ones. So if you have a patient with a longer arm, bony prominences, some will scale up or scale down. But basically the idea is to mimic, I get the reversal of our provocative test. So our provocative test number one was our Phelan's test. So it's sustained wrist flexion there. So if we know a patient with their classical histories at nighttime when they fall asleep in their fetal posture, But it might also be when they're playing guitar, when they're down through here, when they're laying bricks, when they might be doing whatever provocative task might be coming on. The brace can be quite nice. But textbook answer would be nighttime in a neutral posture, being straight for 6 to 8 weeks. And most patients should be able to feel some improvement within the first night. They're not waking up multiple times a night, shaking their hands and being quite grouchy. The second dot point would be something called tendon gliding exercises, which we'll go through right now. So a combination of the brace and the tendon gliding and education on those provocative times should settle down most. So tendon gliding exercises are those biased to help, I guess, improve those flexor tendons running through the carpal tunnel. My simple brain likes to describe these to patients. So you might hear them talking using my lay terms as train tunnels. So our carpal tunnel running through those other flexor tendons being the trains, and gliding those in this order has been shown to almost elicit a WD-40 effect. So it improves the synovial fluid through there. So the idea is, and the glide through there, is a letter L to a touch palm is our FDS glide. So that's the short guys who bend those middle joints, the PIP joints. So it's a set of those. I like to say it's a set of 10. The next one is what we call a hook fist, which is a scratch. So apologies if a patient ever brings my handwriting to your consults, but that's our scratch, and followed by our fist. Now, these are movement-based exercises rather than strength. I always say if a patient comes in and their default is to squeeze a stress ball, lift a weight and whatnot, and they're getting quite sore and they're provoking their symptoms, I sort of say, well, if this was an ankle, this was a knee or a hip, and you're hopping and skipping and jumping on something quite acutely sore, well, it's quite obvious we wouldn't say let's do that. But it just seems to be this default that it's just a hand, it's just a thumb, here's something off the shelf, go nuts with it. But you really need to be quite good at these, let's say these walking exercises here, being these tendon gliding exercises, which have been shown to be the most beneficial way of managing carpal tunnel syndrome, that and the nighttime brace, usually for a period of 1 to 2 months. Now, I tend to say, which we'll touch on the next step, like the 3 options being maybe an injectable plus or minus a hand surgeon review. It really just depends on how they come back, how their subjective history is coming along, but more importantly, when you are reproducing your objective signs, your Tinels being your tapping tests, being your compression-based tests, that you want to just be seeing that score get I guess, bigger and bigger, meaning that the nerve's less irritable. And if they're not, then you'll hear us or hopefully see us writing a letter sort of suggesting, look, let's escalate this quicker because it's starting to impact sort of quality of life and function. So that's our 3 steps: brace, so either custom thermoplastic one, which we're able to cook up on the spot, or a prefabricated one with an aluminium bar on the volar surface, being the palm surface here, with a goal, it just has to stop the wrist from flexing forwards. Some tendon gliding exercises being L, scratch, and fist, and education on activity management and modification.
Ooh. So steroid injections, they generally don't cure, except if carpal tunnel syndrome is early. It helps temporarily. So I usually find that in temporary conditions such as pregnancy, steroid injections are the mainstay for those, because once the baby is out, the swelling comes down, and about 6 to 10 months later, a pregnant lady or no longer a pregnant lady is now happily carpal tunnel syndrome free. So I find that can be very useful. It can help to confirm a diagnosis. So if you're still unsure if the problem is in the wrist or in the neck, sometimes you might find a steroid injection helps to distinguish the contribution that the carpal tunnel syndrome makes to their symptoms. Hand surgery, what do? We do an open release of the carpal tunnel, which is what I do. That's when we cut the ligament that sits across the carpal tunnel, and this allows the nerve to no longer be under pressure. I tell patients float up, but it doesn't really float up. It just means that it's not going to sleep under a really tight bridge. Endoscopic release is another thing that people do as well. I don't do them. And part of the reason I don't do them is because I think that the complications from endoscopic release are pretty bad if they do happen. And the way it works, if I were to explain how an endoscopic release works, is you've got this scope. It's on a tube with a fiber optic camera on it, and there's a blade at the very end of the camera that flicks up. And the idea is when you put the endoscope in, you see what you think is the transverse carpal ligament, you engage the hook, and you pull backwards, and that should divide the transverse carpal ligament. The problem is that I've seen people basically shred a median nerve because they thought it was the transverse carpal ligament. You can't come back from that. I've seen the median nerve slip into the field and get lacerated as a result. Can't come back from that. And I think for the difference of supposedly 2 days of work and a cut about 1 centimeter big versus a cut about 1.5 inches big, I myself would choose to have mine done open. And then, of course, there's salvage surgery. I'm sure someone's probably going to comment about the TV program where the anaesthetist in Victoria is using ultrasound to try and percutaneously cut that ligament as well. We don't obviously do that. And probably many hand surgeons would advise strongly against that. Salvage procedures I put in there because I talked about how you can get you can get thenar muscle wasting and loss of opposition of your thumb as a result of APB no longer working. So salvage procedures involve tendon transfers to try and regain this motion. So preferably, if we cannot have to do that, that would be fantastic. But let's move on to trigger digits. You see heaps of those. So what is it? It's what happens when you get like this nodular thickening of a flexor tendon, and this starts to catch against the A1 pulley. So often you find it's a combination of two things. The A1 pulley has become thick, and so has the tendon. And there's a size mismatch, and the tendon gets stuck as it tries to pass under the pulley. So middle-aged women get it. It's quite spontaneous. The ring, middle fingers, and thumb are most commonly affected. You might as well get the whole hand. The rates we're going. There are grades of severity, but basically sometimes the patients turn out and they just say, that's kind of sore. So you keep an eye on that. And then when it goes to catching and locking, that's a different story. Again, that's really obvious because they pop it in front of you. When it becomes fixed, it's actually an emergency or a subacute emergency. We need to try and release it before the finger becomes very stiff. So when you take a history, you just say, look, what are your symptoms? And the patient usually hold their hand up and show you. There'll be clicking or locking of the interphalangeal joints when they make a fist and open up. It's almost always worse in the morning because they swell up overnight. Here's a hot tip. If their finger is locked and they say, well, this was preceded by clicking and now I can't move it, that probably should be seen quite urgently. The examination is super fast. If you thought carpal tunnel was fast, this is even faster. So we look for the triggering or lock digit. We feel for tenderness over the A1 pulley, and we look for nodular thickening. You can actually feel it. We get them to flex and extend their fingers while we keep our thumb over the A1 pulley, and there's no special tests. Ultrasound is probably the investigation of choice. So here we go. Here's George's hand again. Unfortunately, he does not have a trigger finger that I can treat.
I'd like to add that the camera adds about 10 pounds. So it's...
So here we go. Flexion extension. George's finger is not triggering, disappointingly enough. I'm going to show you how to do this over the index finger, which is a more rare finger to be affected. You look for tenderness round about that area of the metacarpal phalangeal joint.
Yep.
And then you get them to move, and you can feel that nodule actually click and move with your thumb right on that area.
It'll feel like a pea passing through there.
Yeah.
With that very characteristic trigger of a gun in a way as that finger pings back out. I asked Sarah here to put this right after the carpal tunnel presentation because these flexor tendons that are getting caught in, so this is usually the FDS tendon, so that's the one that bends that PIP joint, but it is commonly linked with carpal tunnel syndrome. So these flexor tendons that are usually grouchy as they pass through the carpal tunnel, then are still quite sore, still quite inflamed. They then get caught at the next train tunnel, they like to call it, which is the A1 pulley there. So it's always a question of mine. If a patient comes in with a trigger finger, are they experiencing any pins and needles, notice some tingling? Usually it's they sort of think for a second or two, and then I'd probably say 1 in 2, 1 in 3 would actually come and say, you know what, I've had that either in the past or I have a little bit of it now as well. So that's probably my hot tip that's not there is just seeing if there is any, I guess, vice versa conditions sort of playing up in the background as well. So for hand
There we
therapy
go,
here,
George.
thank you. Hand therapy here really, and I saw a few of these today, really my big thing is just we want to really make sure that we're stopping that clicking. So in terms of a tendon, so this is a little bit different than the carpal tunnel, which is syndrome, which is obviously affecting the median nerve. This is a tendon. So tendons need load. So you'll see the splints that we do give for these aren't a big Zimmer frame or a finger splint that keeps the finger actually still. Yes, that would stop the triggering. We're actually not making enough sort of tendon or like change to the tendon because there's no load associated with it. So the splints that we make, there's a few different ones, and I'll tell you the most easiest one that you can do in practice in about 4 seconds, but really is a trigger finger splint. So it's a thermoplastic splint that we cook up. It looks like a ring, and the idea is that they can still engage that hook fist, but they can't get down to a full fist. So obviously, like in private practice, if I'm on the street and a friend's got it, it's just some some rigid tape that you just put around the PIP joint. And the idea is that would stop them from making a full fist. So we have our thermoplastic options. But if I have a patient who's going, look, George, I'm scrubbing up to do surgery tomorrow, all the way to getting their hands wet quite frequently. They're in gardening gloves. Just some rigid tape, sticker tape, whatever it might be around that PIP joint, 3 or 4 times to allow the finger to somewhat bend, but not to pull through all the way to the end there. So really, my emphasis is always trigger-free movements, trigger-free activities should hopefully help to elicit some improvement here. Again, we've got our tendon gliding exercises, but the big change in this is that we want to avoid a fist. So the hook fist, that scratch exercise, ends either tape or a splint, would be what most patients would sort of walk out with at consultation 1. Nighttime as well with carpal tunnel, nighttime is a characteristic time for this finger to click, trigger, or lock. Again, because our fingers are and wrists are in flexion for a sustained period of time. So at the very least, the patient would start, it's triggering all the time. You go, great, the splint's on full time. We'd then look to wean the splint wear. So weaning would be provocative times, and as well for nighttime, tendon gliding exercises. They respond really nicely to heat, NSAIDs, anything to settle down a grumpy tendon, they work quite nicely with.
So usually sorry, George, yeah?
No, I was going to say the cortisone is usually my next pill. So like you'll, again, hopefully, if you have referred a patient, we're very grateful that you have, I'll always say, this is what we've done. It's usually a splint and some exercise, but corticosteroid injections for me, they do really nicely in this population group. And then I'll always sort of plus and minus, referral to Sarah, for example. But I'll leave this part up to Sarah here.
I usually have a chat with the patients about results because they, when you're going to do something, you want to give them some informed consent, and it's something that radiologists usually don't have time or social graces to do. Sorry, my husband's a radiologist. But I tell patients, look, about a third of patients don't actually respond to corticosteroids for whatever reason. And so 2/3 then do respond. And the question of how long the response lasts or how efficacious the response is, that's a very, very individual response. And sometimes it depends on the patient, sometimes it depends on the hand. So I tell patients, you may get a partial response, you may get no response, you may get a fantastic response. But it's worth a go. It may be enough to push you over. I'm happy to do them blind, but in the rooms, because I think it's very hard to miss a nodular swelling. But I realized that in GP practice, it's actually quite time consuming to get the needle drawn up, to prep the patient for it, and then stick the needle in and do it. So I am mindful of that, and your friendly ultrasound place would be more than happy to do it for you. And then, of course, a hand surgeon once that's been tried. So moving quickly along, I see it's 8 o'clock. We'll talk about first carpal metacarpal arthritis, so basal thumb arthritis. This is the anatomy. The first carpal metacarpal joint is located right at the base of the thumb. The scaphotrapezium trapezoid joint is located below that. The trapezoid sits sort of under the second, or not quite, but it's that little bone right there, and then that's your trapezium. And who gets it? Well, take a guess. generally middle-aged or older ladies get it. It is, first CMCJ arthritis is a little bit different from STT osteoarthritis, okay? Because STT osteoarthritis also has other factors that can contribute to its development, which include metacarpal instability. So it's a slightly different animal. Often STT does follow CMCJ osteoarthritis, just so you know. Causes can be primary, it just happens. Their mum had it young, so they have it young. Secondary, so grit is the mnemonic I like to use: gout, rheumatoid arthritis, infection, or trauma. They usually turn up and say, oh, I just got this unrelenting pain right here and extending
You do a
around
nice
to the
big
back.
C shape at the base of the thumb there. That's right.
Yeah, it's a smiley face and an unhappy patient. So what we look for is a prominent first metacarpal base, an adduction deformity, and MCPJ hyperextension. So I'll show you this again. Prominent first metacarpal base, because what happens is that the ligaments around the base of the thumb become lax with the development of osteoarthritis, and that means the thumb starts to suck lux out of the joint. So you get that. The adduction deformity obviously happens as a result of these ligaments becoming lax. So the patient now has a thumb in the palm, and they're desperate to get their thumb out. So what do? They hyperextend at the MCP joint. So that's how these deformities develop. They tend to feel tender at the MCP, at the metacarpal base. And I'll show you how to feel for that in another video. And when you move them, you generally can feel, if you're lucky, crepitus, but generally you don't feel a lot with this arthritis. And finally, the special test, always do it last because it hurts. You want to make friends first before you make enemies. So the grind test. And here's George. Unfortunately, he does not also have first CMCJ osteoarthritis.
Thankfully.
So we look, yes, right. Prominent first metacarpal base, adduction deformity, and hyperextended MCP joint. Yeah. And they tend to be tender at the joint. Now I'm going to show you where it is around the joint. The best trick is to feel along the radial styloid and where there's a divot, so in the snuff box sort of area. And then you feel around the front and feel around the back. They tend to be quite tender. You can sometimes feel where the joint is too if you've got a good osteophyte going. So I move the thumb around, roll it around. Sometimes if you're lucky, there's crepitus, but that often isn't. I test for stability, so you grasp the metacarpal and move it back and forth. Again, George is unfortunately quite stable. And the grind test loads the thumb axially, and you can see I'm grinding it down there. And you can see why this should be the last test you do, because the patient won't want you to touch their thumb after you hurt them. The orthopods, hey, they love to hurt people. That's a positive test. So the start for workup of arthritis is the same as anywhere else in the body. We do x-rays to help differentiate where the arthritis is and whether there's even a smidgen of STT osteoarthritis, because it helps to determine treatment. As with any osteoarthritis, again, x-ray findings don't necessarily correlate with the clinical symptoms, which means sometimes you are investigating a patient's hand for some completely different reason, and you get an x-ray and the thumb looks terrible. It looks like so advanced. And the patient just goes, oh, that's nothing, doesn't bother me. But other times you see, x-ray looks okay, maybe there's a divot. It's not, you have to get an MRI just to prove that there's cartilage wear, and the patient's in terrible pain. So it really doesn't correlate. So just bear that in mind.
Yeah, and that's because on X-ray, it can only, there are 4 stages of arthritis, so it can only ever pick up sort of stages 3 and 4. So they are usually, when they come, quite delayed, and again, usually it's given them not a lot of bother for a long period of time. Unfortunately, as Sarah did mention, females are 6 to 7 times more likely to develop osteoarthritis at the base of their thumb, which makes it really tricky when we talk about splinting. So this is a thermoplastic splint for a base of thumb first CMC joint arthritis. So it goes on. We put some Velcro at the base. Again, it's made on the spot for the patient. But in a lovely little old grandma who's got sort of quite prominent first CMC arthritis, that can be quite rough on their delicate skin. So there are soft ones. And research does say that, to be fair, both hard and soft work quite nicely, almost to point where they're the same. So we end up sort of, this is where we sort of gauge their hobbies, their work, their functional tasks, and they might have a few different options depending on what they sort of need them for. But splinting is a large day, if you haven't seen of our practice here. So it does get quite arts and crafty, our job here. So we can always make something for any size thumb, wrist or hand. And in this case, we want something that clears the wrist, unless the STT joint is affected. But from the first CMC joint, it's the wrist can stay free, the IP joint can stay free. So we want them using that hand there, which comes into the stabilization exercises. So there are a bunch of delicate sort of muscles that we want to be activating there. So yeah, the thumb makes up about 40 to 50% of our hand function. So when it doesn't behave, these muscles start to deteriorate or sort of don't turn on the way we like them turning on. So we will talk about those two, and as well as the big one, activity modification. So the classical ones for CMC joint OA is the torque force with twists. So basically it's jars, it's taps, it's door handles, anything like that. It tends to grind the cartilage its way here, leading to further either wear and tear or aggravation. So for us, it might be as simple as a non-slip matting that we buy from Bunnings. It's almost like a little present to the patient there, but it works a charm. They can leave in their cutlery drawer. They can pull out for those really tight sort of vacuum sealed jars that are really tricky with saucers and whatnot. But again, it would come down to if there's any way that we can bulk up some cutlery or just tweak that activity to still promote function and quality of life, but minimize that aggravation, because we can do all the right things with splint and exercise, but if we keep provoking that joint, we're going to facilitate that wear and tear process, and I guess push them up the ladder, needing further interventions, whether it's a corticosteroid injection, which I'm not sure if you mentioned, Sarah, which can't say I'm a huge fan of. I find they're really provocative. Sorry, and then a lovely sort of trapeziectomy being the next surgery.
Here we go. Education, lifestyle modification, hand therapy. The top two have already been covered. Oral medication, anti-inflammatories, and paracetamol. Most patients tell me they only really partially work. Corticosteroid injections. Look, I probably recommend that if you do think the patient wants to try one, I think you should refer it to the ultrasound friends, mainly because it can be quite tricky to get the right joint around that area, because the difference in space between the STT joint and the first CMCJ is really about centimeter. If you feel quite confident to do it, that's not a problem. You just feel down the metacarpal till you feel the first divot, and that's the CMC joint. But then again, it takes time, and most of the time you don't have more than that 15 minutes to spend with the patient. So an ultrasound guided injection is probably the better way to go. With hand surgery, yes, we talk about a few options. If it's isolated for CMC joint arthritis, if there's even a smidgen of STT joint arthritis, a trapeziectomy is usually the best thing to do. And that involves taking the bone, the trapezium, and chucking it into the bin. Now, a general principle for orthopedic treatment of advanced arthritis is we treat advanced arthritis in 3 ways surgically. The first way is a joint replacement. And so many of you are familiar with the knee joint replacement, the hip joint. The other way is to do fusions. So spinal fusions are common examples of that, even toe joint fusions. The third thing would be excision arthroplasty. And a very long time ago, we used to do that for, say, girdle stents in the hip, but they work quite well in the hand for thumb-based arthritis. So a trapeziectomy is basically an excision arthroplasty. More recently, though, we do have the introduction of something called a touch prosthesis, which is like a mini hip joint in the thumb base. It's quite new in Australia. It's actually been around in Europe for a lot longer, but it's only really hit the Australian market very recently. We've got a maximum of 5 to 8 years worth of data from overseas. So we tell patients that, and because it's kind of only hit our market now, I tell patients, look, you don't know how it's going to go in 10 years, but apparently the mobility, the DASH scores, functional scores are very good. It's always a bailout. The bailout is you can actually take out that trapezium anyway, that bone, and proceed to a trapeziectomy. The caveat, though, is that because it's fairly new to the market, it's not covered by Medicare. and not by every private health fund either, and it costs $4,000. So if a patient's willing to give it a go, $4,000 for something with fairly short to medium term data, I'm more than happy to try. But I usually have a very, very open disclosure conversation with the patient about the pluses and minuses of that. Moving on to another thing that you see very commonly with thumb-based arthritis, as well with women who enjoy playing with their grandkids who are newly born, and people who enjoy gardening, is the Quervain stenosing tenovaginitis. Is a long phrase, but that's when it clicks. You will more commonly see it as the Quervain tenosynovitis. What is it? Well, we looked at that area around the thumb already, but it's the first extensor or dorsal compartment of the wrist. It's not as dorsal as you think. It's actually along the radial styloid, just there.
Almost in the gut, just near where the snuff box is.
Yeah. And there are two tendons in there, the abductor pollicis longus and the extensor pollicis brevis. And often there's a lot of variability around the tendon slips and how many slips there are, and even whether there's a subcompartment within the first compartment. Again, women don't do very well. There's preponderance of females with this condition. It can arise during or just after pregnancy. Remember how I said that sometimes it happens when people have to pick up objects like this a lot? Well, that's just how we happen to pick up babies, isn't it? So it can happen during or just after pregnancy. Patients complain of pain when they use the thumb. They say that it hurts to use the scissors. They say they can't use a hammer. So they lose that ulnar deviation at the wrist. If you're very lucky, they also tell you their thumb triggers when they try to extend it, and it's very, very sore along the radial styloid. Sometimes when you compare them, the two radial styloids, one is more swollen than the other. So if you're lucky, on your look section of examination, you see swelling. And if you feel along the radial styloid, as I demonstrated before, you see that they tend to be quite tender in those classic locations. Thumb extension is painful, especially when it's against resistance. So if you put your finger there to stop the thumb from extending, it really hurts. So active use of the tendons causes pain. Finkelstein's test is passive stretch of the tendon. This principle works for any irritated tendon. If you stretch the tendon or you get them to actively move the irritated tendon, it will hurt. So investigations can be therapeutic. For example, you can actually put a request form down for an ultrasound like you do for a trigger finger and just say, if there is the Quervain's proven, can you proceed please to a corticosteroid injection? So that can be very therapeutic. And here we have George again.
So speaking
on examination.
No, I was going to say, as with a patient in with the Quervain's, it's it is not a pleasant condition, and I'll talk about my splinting as a rule as well. But I was going to jump to the next one. But yes, it is not just the females. I'd like to say it was a painful few weeks. So mine did settle with a cortisone injection. So I can speak from first-hand experience. It was my sympathy went out to all my patients following that. I had so much. I try to be as nice as I can, but I almost gave every patient a hug after that. It was quite painful with my firstborn.
It is pretty brutal.
So yeah. Sorry, that was just my 2 cents.
That's okay, man. That's okay. Like I've had something similar following reaming out a hip acetabulum or doing a hip replacement. So mine was kind of semi-traumatic, and I went 9 months of splinting before I wound up getting surgery, and that was after several people told me, "Are you mad? You should get surgery." So I tried really hard, and it is quite sore, and mine actually did trigger. So that was quite uncomfortable. So I'll go back to the examination. We look for swelling, particularly in this region, right along there. Yeah. We feel for tenderness in the classic location, which is at the level of radius styloid, and it usually extends up to the base of the thumb and further up the forearm. I get the patient to extend their thumb against resistance. Come on, George. Push, push, push. And Finkelstein's test. I test the EPL as well. It's a third compartment tendon, but usually if it's irritable, it does show it's pretty advanced. Finkelstein's test is performed by getting the patient to put their thumb inside their palm and to try and ulnar deviate, so to try and do the hammer action.
Yep.
And there you go. That's the test, less than 1 minute.
So again, in my youth, prior to my daughter, my firstborn, the mean speech is, again, I need to find a way as a therapist to slow down those two tendons or two trains trying to pass through that train tunnel on the radial styloid. So our answer to that in therapy land is a very mean forearm-based wrist splint that prevents my thumb from opposing, so to get down into that Finkelstein's posture and to stop that ulnar deviation. Now, worked quite well for nighttime, but trying to change nappies, trying to do a lot of things with that, I probably didn't appreciate how difficult it was for patients to stay compliant until I went through it. So that was quite eye-opening. But that is, for best practice, it is what we call a long thumb post splint. So big, long forearm splint that blocks the thumb and blocks that wrist. And usually they come in, by the time they come into, they're so cranky. So really it is just trying to deload that tendon rather than how we did previously try to get things moving right off the bat. But we do want to try to get those tendons gliding when they do settle down. So we do have a variety of exercises we call tendon gliding exercises, again, to try and encourage some loading through that thumb. But the big tip that I always like to say, my strategy to help sort of reduce irritability is I tell my patient to imagine that they don't have a thumb, because it is the abduction or the opening of that thumb that tends to get them. And yes, it is in that ulnar deviation, but a lot of the times it's actually also in wrist flexion. So that is doing a bra up, it's pulling pants up as they're, for me, it was actually pulling the bed sheets over. It is as they try to abduct or get around a task and move around. So for me, if you can tell your thumb to stay by that first finger, keep the wrist nice and still, it ends up being a shoulder and an elbow problem, vice versa, elbow shoulder problem. And using your bigger joints to almost do a more scoopy action rather than a very linear, smaller movement. And that tends to settle some of them down. Again, it is one where you do sort of cross your fingers as Bub does get that little bit older, that and does become a bit more independent, that you can start to deload that thumb. We do have softer splints that we do try as well, but when they are coming in, they're really cranky, they do benefit from a really hard thermoplastic splint. But we just have to try and find that balance of when to use it.
So we did talk about ultrasound-guided corticosteroid injections, and again, the results are the same as everywhere else. With corticosteroid injections, 1/3 respond, 2/3 do. How often can you have these is another question I get asked very commonly, which I forgot to mention earlier. You can have up to, look, it's anecdotal. Yep. We seem to say about 3 injections a year, at least 6 weeks apart, because it takes up to 6 weeks to get full effect from the corticosteroid injection. And if you haven't had it by 6 weeks, you probably could either go again or not at all. So who does them? Like I said, ultrasound centers do them. And if you're brave enough to go blind and have the time, probably it's a bigger problem, go for it. Otherwise, I'm happy to do it.
Jump in there, sorry, Sarah, on the cortisone, because another one is with our, I guess, our classical population group being young mums. There is very low level research, but the research does say that you can do a cortisone whilst breastfeeding with nil side effects of that as well. So it is a really, I guess, a good option for a quick hit when they are so sore, especially when they come in bilaterally as well. That it is safe.
I do think that ultrasound guidance for this particular injection is preferable. Remember, I talked about the variability of the compartment, where there could be a subcompartment. Well, the ultrasound will probably hit all the compartments and subcompartments. And the other thing I should probably mention is, as someone who's had an injection around the bony region of the radial styloid, I can tell you it is really painful. So they'll be very ginger, and often George will have provided them with a splint to put on after the injection. And so hand surgery involves releasing that first dorsal compartment so the tendon glides more easily. Here's a hot tip. If you mention what interventions have already been tried and how many attempts at corticosteroid injection the patient has had, it has helped the surgeon determine the need for surgery, but also psychologically it prepares the patient for what is to come. Skier's thumb and gamekeeper's thumb. You see that a lot, particularly in young people, not so much skiers. Very disappointing, after the moniker of it being a skier's thumb. But what is it? The ulnar collateral ligaments that are located in the first wet space between the metacarpal of the thumb and the phalanx of the thumb. So it's indicated there. This is how it happens. Fall onto thumb. So the closest I got to a ski injury most recently is a person who slipped and fell at the ski slopes while at the car park. So, you know, kind of close. I'll talk about the sternal lesion. This is the gamekeeper's thumb. This is how Scottish gamekeepers used to attenuate the ligament through snapping the necks of hares and rabbits that they used to catch on their properties. The sternal lesion is what happens when the adductor aponeurosis, which runs across that first web space, holds the ligament back from returning to its original insertion site. So it almost folds the ligament down, as you can see from that picture. And that means that the end of the avulsed ligament doesn't actually sit where it used to sit, which means that its chances of healing are pretty much zero. So the hot tip is a sternal lesion means that the patient is much less likely to heal without surgery. A great picture. This one is from a colleague, Stuart Myers, who has this picture on his website. I'm sure he wouldn't mind it if I shared it, because I think many of you probably already know Stuart. So the history would be a fall or direct blow into the thumb in adduction. The pain in the joint tends to hurt with movement, and they have difficulties with pinching. They feel that it's very hard to open, say, a jar or bottle because they can't trust their thumb to stay where they put it. So examination, I don't think we have a video for the examination with George's hand because he's got a stable ligament. But you look for bruising and swelling along that inner aspect of the thumb. So in there, here we go, then right in there. Thanks, George. We feel for tenderness around the collateral ligament. Sometimes we also feel for the volar plate because sometimes it's an instability event and it kind of goes around. We move the thumb, we move the MCP joint. Sometimes there's crepitus. And the special test is one that tests the stability of the joint and full extension of 30 degrees of flexion. I actually think we do have a video. Here we go. Here's George's hand. That's the joint you're looking at. Right there, that's where the ligament sits. So we look for swelling and bruising, and then we palpate for tenderness at this region. Now, radial collateral ligaments also do get avulsed at almost a similar rate as ulnar collateral ligament, so it's always best, if you need to, flip the exam to check for the radial collateral ligament as well on the other side, volar plate. Here we get range of motion. So I extended George's thumb as much as possible, and then I flex it as much as possible. The stability test is a special test that specifically looks at the ligament. Very hard to do when it's acute, but when it's not as sore, it usually opens up. So what you do is you grasp the metacarpal and apply an outward force and an inward force. 30 degrees takes out the component of the volar plate because it slackens off. There you go. That's the test. When in doubt, check it against the other side. Unless they have a bilateral problem, then you're in trouble. So hand therapy, George.
Yeah, I guess for me that special test, which isn't like in all, like it is your ACL test. It is your one that you do to assess a knee or an elbow. It's just a smaller joint that we get to play with. For me, whether we need to scale up or down will depend on the stability of that joint. So there's a lovely video coming up and talking about an unstable joint, but for us, the ones that we can help with tend to be only the stable ones. The one that are unstable always would need a specialist review. So the problem that we have with this is it's always helpful to have an x-ray. Usually there is a sort of pronounced bruising and thickening on that ulnar aspect. Even the radial aspect wouldn't matter. So an x-ray is helpful to see if there's usually an avulsion. So if we've injured the ligament so well that we've either ruptured it, or if it's been so strong that it's chipped a bit of bone off. And then that can help with Sarah's sort of, I guess, surgical planning as well. But for us, the ones that we would deal with would be either grade 1 or grade 2, where it's a stable joint, there is pain associated with it, but we're dealing with a ligament, which we know is relatively avascular, so it has a poor healing potential. So for us, we go back into our thumb splint here, and the idea is to lock that MCP joint up, being the one that bends that middle joint there, for a period of time. Now, a textbook answer could be 6 to 8 weeks. Usually it's longer. Sometimes it could be shorter for the youngsters. But my assessment is always going to be palpation of that joint, comparing it to the contralateral side, the stability tests in 0 and 30 degrees of flexion, range of motion, and we have there's sort of grip strength ones, but we also have pinch dynamometers. So I want to make sure that the patient's that joint is happy, because this is the equivalent of a moon boot per se. It's easy to take on and off with some Velcro straps to do some exercises, so they don't just waste away while they're under the joint there. But really, it always comes down to the stability. And if we're ever unsure, we can refer up for an ultrasound to confirm that. But it is such a eye-popping, assessment, which you see in the video. Just when it is grossly unstable, it's pretty hard to miss, I would say.
There you go.
I guess very rarely, so just on this one, I guess very rarely would I cast them though, unless I had a very naughty patient who I really didn't trust. But even then, that can sometimes be a little bit mean. But they're probably my preference would be a splint, I would say.
Mine would be too.
Yeah.
So hand surgery review sooner is better than later, because if you leave it for too long, the ligament becomes a bit mushy and more difficult to repair. So here you go. Earlier referral to a hand surgeon is better for the patient because treatment's more straightforward. All right, you guys ready for the video? Here we go. This is a lady who fell in the car park. So as you know, a thumb is not meant to do that. And after you repair it, you can see that the thumb moves with the metacarpal together, that it doesn't open up. Hopefully I grossed enough people out. This one usually gets a good reaction. Dupuytren's contracture. Finally, we're moving into stuff that's a little bit more static. What is it? Margaret Thatcher had it. This guy, Bill Nye, the actor, had it. Has it. In fact, he's never had it operated on. So next time you watch him in his videos, you'll notice that he's always got them curled over like that.
Got them worse actually than that.
It's quite remarkable. I think he surgery had been discussed with him, actually. I think that he was at a point in his career where things were going really well, and he didn't really want to take the time out for surgery because there's a lot of rehab involved. I believe that that's the story. So it's a benign connective tissue disorder affecting the palmar fascia of the hands. Myofibroblasts are the active cell in discussion in the pathologic cause. And what happens in the myofibroblasts is they contract. And this causes progressive flexion deformity of the fingers, kind of like you can see on the clinical photograph in the bottom right-hand corner. Well, who gets it and where? Oh, finally, men get it more than women. Northern European descent. So most patients come to see me and they can't remember the word Dupuytren's, but they can tell me, oh, it's Viking disease. They go, oh, okay, there you go. It's also known as Scottish bagpiper's hand, by the way. And it seems to me that in a recent study, obesity is protective. So you don't tend to see it in larger men that often. The diathesis is the one that's quite interesting, because people who have Dupuytren's diathesis get it young. It's in both hands. It's extensive. It often affects other parts of the body, including the feet and the penis. And once you mention that, you find most male patients can't wait to get out to go to the bathroom and check. True story. Assessment. How do we do? George, stop laughing. So the story is they'll say it started off as a lump, and it didn't really bother me much, but now my finger's like this. Okay, all right. The duration and progression is quite important, because it gives you a bit of a guideline as to how they're going to go, and whether if they get it at 70 and they say, oh, over the last year it's just gotten a little bit worse, you'd be like, oh, you probably get through to 90 at this stage. So progression is pretty important. How does it impair their function? Whereas they can tell Bill Nye can't shake hands. Margaret Thatcher had it, and she had surgery done on her hands. So it can impair function. I once saw a patient with bilateral Dupuytren's like this, and all he told me was when he plays with his young nephew, he just wishes he could clap his hands. So it does impair function. Often people say they go to wash their face and they poke themselves in the eye with their finger. So it can be quite, quite irritating. When we look for it, so George doesn't have Dupuytren's, so there's no video examining George's normal hands, but we look for skin puckering We look for the nodule, which can be painful in the early stages of Dupuytren. We look for a cord. Often I get it referred to me almost as if it's a really prominent tendon. So that is a common mistake as well. Or a contracture. It's usually in the 4th and 5th fingers. You can feel for a hard nodule or cord in line with the digit. It may or may not be tender. You get them to move their MCP joint, PIP joint, DIP joint, but the hallmark of Dupuytren's contracture is its flexion. It's not extension. Houston's tabletop test is one of those composite tests. Again, you get them to put their hand down on the table. They can't achieve palm to table. That's considered a positive tabletop test and definitely worth a referral at that stage. John Houston, in fact, was a hand surgeon who specifically had an interest in Dupuytren's, and he came up with this test. Investigations, the X-ray if you're worried about other causes for contracture, and ultrasound if you're in doubt about the nodules. Is this a lump I should be worried about? Is it malignant? So an ultrasound may help to define what layer the lump is in. So when do you refer Dupuytren's to see me? Well, you get a positive tabletop test. If you think that the disease is progressing quite quickly, or you think that it's changed over the year. And the indications for surgery include MCP joint contracture of about 30 degrees or more, or PIP joint contracture of 20 degrees or more, and progression. Now, I will say the caveat is PIP joints, so these, not the big knuckle, but the little one here, they don't like being contracted for too long, as we probably discussed in the trigger finger topic. So we tend to be a little bit less forgiving if they have a smaller contracture than the MCP joint, which bounces back no matter how badly contracted it is. So if you do see a PIP joint contracture that you're concerned about, send it to see us. It's not just the contracture on the front, but it's the ligaments on the side of the joint that get quite tight. And if they get tight, it's very hard to correct without a joint release. So the goal of surgery is to improve function by releasing joint contractures. It's not curative. So we have to have a talk to the patient about the fact that it's a disease of skin. And surgery doesn't cure a disease of skin because we can't cut out all the skin. But what we can do is take those cords out. So there's no perfect surgical solution for Dupuytren's disease. It doesn't cure or eliminate the disease. And at this point, usually people ask me about this. Is there an injection for Dupuytren's? Yes, there was. And it's still in use in other countries, but not in Australia anymore. It's for some reason, it has been approved by, I think, the TGA, but it's not paid for by the PBS, so it kind of petered out of use. So we don't use it now. Hot tip, the more advanced the contracture, the more difficult surgery becomes, oh boy, and the less predictable the outcome, especially in the PIP joint, as I mentioned. Mucous cysts. We see them a lot. Because arthritis is common, and common things happen commonly, and the associations with these common things also occur commonly, like mucous cysts. So, what is it? Most commonly, you see them at the distal interphalangeal joints of the fingers, so the little knuckles just shy of the nail. In the thumb, it's the interphalangeal joint of the thumb, again, just shy of the nail. It's a fluid-filled sac with mucinous material, so you can actually shine a light through it, and it lights up like a little light bulb. Who gets it? 50 to 70-year-olds, women again more affected than men, and it's associated with often early osteoarthritis of the DIPJ, but I've also seen it in fairly advanced arthritis. So the DIPJ, I did say that it has arthritis, but the pain is usually mild because it's quite early. More often, there's a little spur that causes ongoing irritation and the production of mucoid material, which then gets collected into this sac. It's often associated with nail grooving, and sometimes the patient turns up with a nail groove or nail ridge and says that, I don't understand, man, I've had this for quite a while, and you have a really good feel. There's a small little occult mucus is pushing on the nail. On the alternative side, they can tell you that this mucus has just popped up, but you notice the nail grooving, and you know it takes months for the nail to grow out like that. So you know that the story of it being quite quick is actually not quite true. What we look for is skin translucency over the top of the cyst, because the thinner the skin, the less likely it's going to heal if it pops. Risk of infection. Transillumination, if you have a torch handy. Ulceration, so you want to know if the patient's had a go at it. neogrooving, and Heberdin's nodes, looking for arthritis or osteophytic prominences around the DIP joint. We feel for DIPJ tenderness, but I've told you this is often quite mild. And we get them to move their DIPJ. So we get them to make a fist and we look at their range of motion. We look at their extensor tendon function, so get them to straighten the finger against resistance and see if it's good. And we get an X-ray. Usually there's an osteophyte that you look for on the DIPJ, like I said, a spur. An ultrasound, if it's obtained, confirms a cystic structure with very little inside and often not great vascular supply and an intact terminal extensor tendon. So the main thing is tell the patient it is not a pimple. Do not pop it. Don't take it home and just have a go at it, with a needle. And the reason for that is because the mucinous material in the cyst comes from somewhere, and it comes from the joint. So if you pop it over the top, you expose your distal interphalangeal joint to the outside world, and therefore you risk septic arthritis. Now, I've probably seen that twice. Patients have popped the mucinous cyst. In one case, it was misdiagnosed as a wart, and cryotherapy was applied. And the patient wound up in hospital getting IV antibiotics and 2 operations to try and clean out that joint and save it. So, look, it doesn't happen often. Often people pop it and get away with it, but the bottom line is if they don't pop it at all, it's probably better off. Asymptomatic patients with very nice, thick and healthy skin over the top of the cyst can be reassured and observed. But when it becomes paper thin, that's when they should see someone. That's the bit under hand surgeon review. Translucency of the skin means there's a risk of breakdown of overlying skin, and then you've effectively popped it. Pain may not be alleviated with surgery. This is a conversation I have with all my patients, because if the underlying cause of the pain is actually the osteoarthritis, taking the cyst out is not going to treat that problem. So the hot tip is, please refer the patient before the skin overlying the cyst becomes too translucent. Don't attempt to pop or drain the cyst. Now, wrist ganglions are, again, a very similar sort of pathology. So sorry about the wordy slide, but that's a photograph of an actual patient who had a spectacular one. As you can see, it's translucent. It's got a really thin cysty-like structure. You can also see the lobules in the cyst, which also explains partly why sticking it with a needle may not get all the little chambers within the cyst. You can also see that the material inside it is a clear, thick, jelly-like material. The theory is that repetitive microtoma to the capsule or the ligamentous structures around the wrist produces hyaluronic acid, which is, as you know, a joint fluid component. And what happens is that it forms a little balloon with a neck from the joint. There's a one-way valve with that neck, so often you'll find that unless that valve gets cut out or the neck gets cut out, the cyst tends to recur. Who gets it? Well, it doesn't matter if you're right or left-handed. Hand dominance is not a factor. It's slightly probably more in women than men. It does tend to turn up in a gymnast wrist. Look, I thought I should make a point that if you were to MRI the entire asymptomatic population, you probably find that up to 50% of people have ganglions. So ganglions are quite common, and I've seen so many people come to see me and say, it's the ganglion that's the problem, can you take it out? But their pain is nowhere near the ganglion. So just bear that in mind. People can get quite fixed on the idea that the ganglion is the cause of their pain when it's not. So, but there you go, MRI, up to 51% of asymptomatic people have ganglions in MRI. So there's 3 ways to manage a ganglion. And this is the kind of bit where you have to have a chat with the patient, convince them that, look, we can observe it. And that's when they stay quite close friends with you and they come back and have a look at it. And if the symptoms change or it becomes painful, that's when, you can refer them on. You can get it aspirated. This is usually done under ultrasound guidance because you want to try and get all the chambers. And also they like to throw in a steroid injection in there. But it's actually not been shown to be superior to just the aspiration. So it's the same it has the same result. Aspiration has a recurrence rate of up to 78%, but sometimes it's more. And the reason for that is because they don't address the neck or the cause of the ganglion. So that one-way valve still keeps flapping away, fluid still keeps coming out the joint, the balloon will reform. We don't often recommend an aspiration in volar wrist ganglions because they tend to be located right there, very close to the radial artery. Excision actually has better odds. Still, I reckon the recurrence rates are reasonable, like 8 to 10%, is not low, but it's definitely better than getting a needle put into it. It really depends. You can do it open or arthroscopic, especially for the dorsal ganglions. I prefer open because, once again, I think that the risk with arthroscopic surgery, you're going really close to tendons there. You could wind up with rupture from shaving too close to a tendon. It's same recovery rate. I'd probably go open.
Mm-hmm.
George, thoughts?
No, so my only bias is, I guess, under the observation guide, like if they are stemming from a scapholunate ligament injury, which they commonly are on the dorsal aspect at the very least, they can be quite, I guess, well managed with therapy. So the idea would be, maybe time for another chat, like looking at that scapholunate ligament, which is almost like our ACL of the wrist. It is such an important sort of primal stabilizer of the radiocarpal joint. So a lot of the times they do stem from partial tears. So you can, again, keep addressing that symptom of the scapholunate, which is usually the cyst. But again, it does stem from some further looking at, which is where the MRI might be helpful to figure out for therapy and surgical planning as well.
Yeah. And finally, triangular fibrocartilage complex injury, so that's the TFCC. I think you see a rise in these actually now. Back when I was training, it was like, what? But now you tend to see a lot of these. So what's the triangular fibrocartilage complex? If you imagine I'm the ulnar, my arms come around like so, and my fingertips at the end are touching the radius. That's what the TFCC sort of look like, and it allows me to rotate around the radius, right? So, and that's a more complex picture of the anatomy, but very simplistically, it's a shock absorber for ulnar deviation around the wrist. It helps to stabilize the ECU tendon, and it helps to stabilize the distal radioulnar joint. So how do patients present with TFCC injuries? They tend to present with ulnar-sided wrist pain, and probably the most pathognomic one is in the ulnar fovea, which is right in there, just distal to the ulnar styloid. If you're very lucky, they have instability signs, and we have something called a piano key sign, so you can see the ulnar kind of keying up and down against the radius when you stabilize the radius. Shock test is when you grab the ulnar and you sort of give it a really good toggle, and what happens is it moves far more than you expect it to. Investigations, look, x-rays generally are normal. MRI is quite sensitive and almost 100% specific. Diagnostic arthroscopy is our gold standard, but obviously it's also very expensive gold standard, with expensive in time and cost. So that's a rough breakdown of the TFCC. Okay. There's two different ways to think of the TFCC as well. You can think of it as peripheral or central. The peripheral repairs tend to be acute injuries, so they've pulled off the attachments around the ulnar styloid and the outside ring. The central tears we don't tend to repair. It's really actually a good subset of the central tears are thought to be chronic, but usually it's quite hard to repair anyway, so we don't repair them. We usually debride any catching flaps, but we don't tend to repair the holes. So here you go. Here's a good piano key sign for you in this young soccer player. And you see how that ulnar is just moving as she just presses down on the table. There's no stability there. So that's a piano key sign. I did talk about the different types of TFCC injuries, but basically it's an anatomical classification, and acuity is the other thing. It's usually picked up later because patients tend to say, oh, it's a sprain, it'll be fine. It's not fine, you know. Non-operative management is a Munster above elbow splint for 6 weeks. So these are extremely popular with patients. I'm being facetious, they hate them. They can't bend their elbow.
Fun to make
They
though.
can't, mainly, they actually, it's not bending. They can't pronate or supinate for 6 weeks. And then they go to a below elbow splint where they can pronate or supinate, but they can't flex or extend. So we're bringing back components of their movement over time. The Minster splint above elbow tends to be quite restricted for pronation, supination, flexion, extension, ulnar and radial deviation. And then you head towards the below elbow splint where you allow pronation and supination, but none of the others. You can try injections for ongoing pain and discomfort or chronic TFCC tears. And operative management, that's where I come in. We look at arthroscopic debridement of those flaps in the central tears. You can look at arthroscopic or open repair of peripheral tears of the TFCC. And the final caveat is probably a term that you guys might have heard of as well, ulnocarpal abutment, which is when the ulnar is relatively longer than the radius and sits a little higher. And if you can imagine that the trampoline of the TFCC sits between the ulnar and the rest of the wrist joint, if your ulnar is longer, it will keep rubbing on that TFCC and eventually wear its way through. So that's called ulnocarpal abutment.
And that can actually happen quite commonly, sorry, Sarah, with conservative management of distal radiuses. So if your radius does shorten as a result of a fracture,
Gotcha.
so that ulnar, which remains intact, is now relatively longer. So that can be and that's quite easily picked up on an X-ray actually as well. You just have to sort of just make sure that you're not looking just at the fracture, you're looking at the other side of the wrist as well, and just going, is there contribution of because it also tends to be quite central, this ulnocarpal abutment. It tends to be almost like, rather than it being just quite ulnar-sided, it can also, I guess, simulate a wrist sprain per se as well, where a ganglion would be almost around that area there. So I guess just to be mindful about that. Yeah.
So it's so that abutment stuff, like you usually can't repair a TFCC unless you shorten the ulnar first. It's a bit of a long process to explain that to the patient. That we're going to have to cut out a bit of bone, and then we need to put plate and screws and kind of shorten down your ulnar just so that we can fix your TFCC. So you got to kind of explain that to them. The thing with rehab time for TFCC tears is like surgery doesn't shorten your rehab time. It's still long. I still tell them you're looking at about 4 to 6 months of rehab, regardless of whether you go with open or closed treatment. So these are some arthroscopic pictures that I've taken in another patient. And what I've done is I put a little probe in there and I've lifted up the TFCC from the periphery. You can see how that bit I've lifted out is actually meant to be well and truly attached to the back, but it is not. It lifts up. So that's called the hook test. The second test we do is a trampoline test, which I haven't demonstrated here. You can probably also appreciate that in the background, the wall of the joint looks a bit red and spotty. That's synovitis. And that's the synovitis that happens with that pain and instability from TFCC tear. The bottom right-hand picture shows, if you can see a little glimpse of blue, that's the suture I've used to repair that peripheral tear. This is an arthroscopic repair. Again, you can see the fronds more clearly now that there's no TFCC in the way. They look like an anemone. So with fronds like that, who needs anemone? Oh, no one's getting it. That's a dad joke. But anyway, that's that synovitis I was talking about again. So that got shaved off later. But that is the TFCC peripheral repair done arthroscopically. So we've come to a conclusion. We haven't managed to cover everything, but it is almost 9 o'clock. So we're going to open it up for question time soon. Other popular topics, if you want, we can come back and have another chat about things you guys see in sports or in acute presentations, things where patients come in and it's really urgent, things like traumatic amputations, so the tip injuries, de-tipping injuries of the fingernails, lacerations, principles to manage that, closed tendon injuries, skiers' thumbs, fractures, scaphoid fractures, see that all the time, the algorithm for managing that, and infections. So more than happy to run a second session and cover these with more time. Questions or comments? Here's the hottest tip of the day. Our contact details. I've said before...
Yeah, no, it's probably going to be your next line. Like, we're a phone call away if there is anything that comes on. And thanks for putting your mobile there, Sarah. But it is like there's always availability, at least through therapy arms, to help triage whether it's something that needs to go on to Sarah, needs to be referred to Sydney Hospital, or can be managed, I guess, through therapy. So it's not any silly questions or any time you're going to hurt feelings. It's more, what do you think? And it can just be something that can easily be fitted in and looked at.
So, I mean, the thing is, like, I've often found that my orthopedic colleagues can be somewhat difficult to get along with and to call. I find that they tend not to be as approachable. I hope that tonight I've shown you that I am actually approachable and a little bit different. And I'm more than happy to be contacted easily. You might find it easier to take photographs or of X-rays or finger, and then text it to me and just give me a really brief history and say, what do you think? What should I do? I'm more than happy to do that. Fortunately, not all 88 of registrants actually turned up, so they don't all get my mobile number straight away. But my secretary told me that she's expecting lots of phone calls. I just want to put it out there that I am actually very happy to be contacted if you've got any questions any time of day. I'll try to help, unless if I'm putting the kids down. But that's where I am. I work in Kogarah. That's my office is near the police station. It's 2 floors above Southern Hand Therapy in the Kogarah Clinic. And they also have a very, very helpful branch in Sutherland as well.
Thank you very much. Thank you. Very informative, very interesting presentation. I will handle it to Janine to go through the questions now with you. Thank you, Janine.
Thank you. That was a very excellent and practical talk. We have a couple of questions. How much muscle wasting do you get after splinting for 6 weeks?
I was just actually typing back and replying to this one. So realistically, it's not 6 weeks and set and forget. So depending on irritability, I guess my go-to answer is something quite grumpy. I'll see in about 7 to 10 days time, 10 to 14 for the moderate to chronic ones, if not even longer than that. So very rarely do they sit in a splint and do bugger all. So it might be resting for a smidge of time, usually a week or 2 max. But otherwise, if it's deemed appropriate and safe, and we do have, I guess we've got ranges of motion that are safe, or positions that are safe to not load, whether it's a UCL or it's a wrist or TCC. So, so realistically, there's always something that the patient can do. So the answer should be little. They should, if they are getting stiff, it's because we want that joint to stiffen up to promote healing or to, I guess, improve stability. But the answer should be, if a patient's getting stiff, it's because either patient's been naughty and done the wrong thing, which is very rare. They usually like to move too much, they're not enough, or they again, it's so-called inappropriate treatment. So realistically, stiffness post for stiffness and wasting shouldn't be something that should be a complication, if I'm being mean.
All right, thank you. And someone wanted me to ask that, I think Sarah mentioned early, occasional cervical causes, but how do we tell if a person has hand and forearm pain if there is a cervical brachial cause, if there's no other classics of approaches?
Great question. I tend to use the ASIA reference. So that's the Spinal Injury Association. There's a PDF you can get online. So I find it quite useful to be able to determine whether it's a root problem or whether it's a peripheral nerve problem, and that can be quite complex. Yeah. The quick cheat is to get nerve conduction studies which can distinguish them. And the other thing I often see is a double crush problem. Now, there's some controversy in the literature about the existence of double crush, but really, I guess it's a very poor term to describe pathology along the nerve at different spots. And I find it's pretty important to tell the patients, look, you've got cervical radiculopathy, which is contributing to your pain in the T8 distribution, so it's around, or T1 distribution, so it's around there. But you also have carpal tunnel syndrome or ulnar nerve symptoms, so T1 goes to ulnar nerve. And so we can treat your ulnar nerve, but you need to know that your recovery will probably be partial unless we can treat the T1 as well. So it's being able to actually assess your dermatomes and your myotomes based on that spinal injury chart, and work out whether the myotomes and dermatomes are very specific for a nerve root, or whether they're due to a peripheral nerve, which is usually a combination of a few of the nerve roots. Does that kind of make sense?
Yes, no, thank you. And reflex sympathetic dystrophy, which is also complex regional pain syndrome, Is this a complication after surgery?
Unfortunately, yes. And not like, yeah. Sarah, that's a surgeon question. I'm not throwing any surgeon under the bus.
So yeah, in fact, it is most commonly heralded by minor surgery or things like carpal tunnel release or fall into hand. The ones I see quite commonly are minor surgery, and they about 3 weeks after surgery. So usually there's a small window in the post-op period where they're actually great and they're like, I feel good. And then after about 3 weeks is when things start to deteriorate and they get quite swollen, and you start to see it looks like you're going backwards. Why aren't you getting less swollen? You're more swollen now. Your skin is looking shiny. So it's probably pretty important to have a radar out for it. Look, the risks of getting it are somewhere, depends on the literature you read, but it can be about up to 1%, but it's often less than that. Tends to be females yet again. And they tend to be on a particular type of psychotropic drugs, particularly lithium. And I think that's because it kind of changes the way the nerve channels are transmitting their neurotransmitters. So they tend to be a little bit more sensitive to minor trauma causing CRPS. There are CRPS, basically, when you get it, it's a year of, at minimum, hand therapy is the mainstay of treatment, pain specialist involvement. So there's quite a few that I use in Kogarah, but I believe that there are also pain specialists in the Shire. And often they need psychological review as well. Most people with CRPS or reflex sympathetic dystrophy have gone months before someone diagnoses them with it. And by this stage, they're so depressed because they feel that no one believes that they have that much pain, because everyone tells them, you had minor surgery, it shouldn't be like this. Oh yeah, it shouldn't actually. It's a complication that can happen. So that's RSD. Yes, it is a complication of surgery, but it can also be a complication of people just falling over and getting a minor little chip fracture in a bone.
Part of the
surgery for
the one that
no,
I was going to say the one that I see of is actually even just in inappropriate immobilization. So it's a cast that's on too tight for a conservatively managed distal radius. It's the cast, and we can pick on it actually extends too distally, so that the patient can't pump their hands. So it doesn't have to necessarily just be a surgically managed injury as well. So conservative management can also, or conservative injuries or closed injuries can also lead to them as well.
That is very interesting, George. It's not always my fault.
No, never.
Someone's made a comment that it was a very practical and useful for GP presentation. They wonder whether it's possible to get a copy of the slides for reference. We are video recording; it should be on the CESPN site. But could they get? Can the attendees get a copy of the slides?
I want them to reach out to you, Sarah, because it's quite a large file.
It is a very large file. So I think Janine and Lydia have copies of the slides, and obviously there's a recording as well. Surgery for the Quervains is very similar to trigger finger, and it's very similar to carpal tunnel. So the issue we have with the Quervains is, again, it's a size mismatch. You've got a swollen tendon or two, and they're getting caught in this dorsal compartment every time you extend the thumb. So surgery for the Quervains involves release of the compartment. To be honest, the Quervains is miserable. Its treatment is miserable. I've often found people who have the Quervains surgery, we quote them something as high as a 17% chance of developing a superficial neuroma, which can be quite painful. It's not insignificant, actually, because you do have a lot of sensitive nerves going around that area of the hand. It's quite bony. Anything bony does tend to hurt when you operate around that. So rehab can be.
Yeah, it can be hard, and I think just to preface as well, with some of those conditions tonight, Sarah, as well, is a carpal tunnel release, a trigger finger release, like mainly the release surgeries, and that you're actually not doing anything to fix the median nerve in surgery. You're not actually doing anything to fix those tendons within surgery. Sure, you might be able to clean up a little of the synovitis around there, but that nerve does take time to recover. These tendons that are cranky for weeks, days, weeks, months, years, don't just start flexing all of a sudden and they've got full range and pain-free within days and weeks. I don't think we'd expect that if it was an Achilles or a patella tendon to do the same sort of thing. So these recoveries are usually 2 or 3 months at the bare minimum. I tend to say for a median nerve, its recoveries 9 months before a patient might be feeling significantly better, because all again our lovely surgeons can do is to release rather than, there's no repair. There's nothing necessarily to improve that tendon overnight, basically. So recovery can be slow, it can be frustrating, as you said, but usually there's no triggering. Oh no, there is no triggering. The patient usually does wake up and there's improvement straight away, but things just take some time.
Yeah. And just lastly, just a practical thing. Doctor, where do you send, what ultrasonography places do you find useful that sort of tend to specialise in if you're looking at tendons or injections?
Oh, the poor guy must be inundated. He's on his way towards retirement, but I like John Corber. He just loves hands. He's about 70 something, and he's still doing, I think, once a week, once a month.
At Miranda. So every Wednesday's at Miranda, and I think it's at Prince of Wales, alternating Fridays.
Castlereagh, St Leonard's as well.
What imaging place is he at? Sorry.
So he's at IMED.
All right.
Yeah, in Miranda.
Emily Davidson's another really good one, but again, her and
She's lovely.
And James Linklater are they're both Castlereagh, but they're not local, unfortunately. So they're the other side of Sydney from memory.
Right. That was a really excellent and practical and very useful talk, and there's a lot of effort's gone into making that in the video. So I'd like to thank you for a really informative education evening.
Thank you for having us. It's always fun chatting with Sarah, and I hope you guys really got something out of it. Tend to say, like, the videos are great, but there isn't quite nothing like a, I guess, pun intended, a hands-on assessment as well. So I guess if we're lucky enough to be invited back again, a in-person one can be a fun one to actually get some practice on as well. But again, thank you so much for having us. I've sipped 2 cups of coffee and I'm feeling good.